I want to thank the faculty for accepting my presentation and for allowing me to come today. The good thing about going first means that I don't have to follow a really good case, so hopefully I'm not setting too high a bar for the rest of the guys coming after me. So I'm Dan, I work in Iowa at the moment, but I think I'm the only Australian, despite the South African that's claiming to be Australian in the corner. So don't believe him, he's fake, he's from South Africa. So, all right, so disclosures, only that 60% of the time, it works every time. And I want to thank Joe Kay and Neil Wilson, who I had the pleasure of being his last fellow. And anyone that knows Neil knows that I was trained well on how to deal with disasters, because Neil gets into lots of them. So, all right, so this case is a 31-year-old male who in 2002 had a Ross procedure. He had progressive homograft obstruction and then had an aortic root enlargement with a 30mm Valsalva graft back in 2013. And then he came to us due to increasing exercise intolerance and plan for his percutaneous valve. So this is what we did in terms of our pre-op MRI. And for any of the keen imaging people out there, you can kind of see the course of the coronary artery here and how it's running sort of just behind the outflow tract. But if you look at the images on the left of the screen, you'll see how the pulmonary artery sort of does a quick turn right over the top of the coronary. So we kind of looked at this more after the case than we did before the case in terms of where it lied, but we still had a good look at it beforehand. So this was his initial hemodynamics, so as you can tell there's a gradient there, he needs a valve in, so we went ahead with the case. So this was our 3D rotational. So as you can see there, there's, you can see where the homograft is and how it narrows sort of at the distal end of the where it's attaching into the MPA. We did that with a multi-track. And so from that we then did some serial dilations starting from a 16 atlas up to a 24, and then we did a pigtail in the aortic root. So for any of the keen eyes out there, can you see, what do you think about this? Can you see anything abnormal there on the 3D rotational? So I think Alison saw what it is, but yeah, so there's the coronary arteries is a fistula through to the PA. So when they've done the Ross, haven't attached the coronary completely, so there's a fistula through to the PA. Yeah, if people can't see it, I'll see if I can. The mouse doesn't seem to want to work. Hang on. Is there a pointer? Will that work? Yeah, so if you see here on the coronary, you just see this puff of contrast that's going out of the coronary as it comes around just there. And so you can see that's where the coronary fistula is. So, and the other thing in this picture is just where we had our balloon placed. So as we said, there's a coronary artery fistula, but we felt that based on the size of the fistula that we would just continue because this guy hadn't had any symptoms from it. So we then did a selective left, and that shows that fistula a little bit better. So you can see where the origin of the coronary is and how just where it attaches in the sort of superior part that there's a fistula through there. So what are people going to do next? Who's going to, hands up quickly, who's going to do a valve? Who's going to go to surgery? What's our thoughts? Valve or surgery? Obviously we went valve, so I'd say most people in this room probably would have done a valve. And then which valve? We got a 24 Atlas balloon up here and we felt we could go bigger, so we thought a sapien valve was going to be our way to go. And who pre-stents? Hands up if you would pre-stent in this situation. So, yeah. So we sometimes don't, but in this case we felt the distal part of the homograft was stenosed and that needed to be enlarged as well to allow the valve to function better, so we decided we'd do a stent. So this is our stent. We put an LD Max 36mm onto a 24 bib, and we had nice placement. You can see there that there's, the stent's nice and well seated. But because we were going to put a 26 valve in, we thought we'd just go with a 26 balloon to try and dilate that a little bit further. So actually, I'll just go back one step here. And I think, does anyone remember the angiogram from a few shots ago where we had the balloon occluding? Our balloon was a little bit further back than our stent is at the moment. So we didn't actually balloon test this part of the conduit in hindsight. So we decided to further stent, balloon the stent up. So we went with we were going to go with the 26 sapien, so we went with the 24 Atlas Gold just to really, because it was only measuring 21, so we really wanted to get this thing quite a lot bigger. And so we did that, and then we were pretty happy. Our angiogram afterwards looked good. The stent was a good size now. Everything was fine. So we all got happy, and this was his hemodynamics while we did the angiogram, and then 30 seconds later, that was his hemodynamics, and then about 1 minute post, we're all doing stuff. I'm helping prep stuff. The anaesthetist is getting stuff ready. The tech who's meant to be monitoring out in the office is not paying attention. That's another 30 seconds later. And then I look at the screen and I said, I think something's wrong here. And so, like all good fellows, I flushed everything to make sure it wasn't a line error. And then this is, I flushed the line and I was like, nope. And then just like Ron Burgundy, I was immediately regretting that decision. So, and then that happened. And by this stage, this is what followed next, the angiogram that I hope nobody ever has to do, where you're trying to, during CPR, get an angiogram done. So as you can see, there is absolutely no coronary flow anymore from the left main coronary. I mean, obviously it's hard to get under CPR, but we had good pressures during our CPR and good end-tidal CO2, so we were actually happy that that if the coronary was there, we were going to perfuse it. So we had complete left main. So as I said here, CPR is initiated. We got the guy onto femoral bypass quite quickly. We always put in an extra venous line, and then obviously you go through the sheaths that you have. So we got our surgeon to come in, we got onto bypass, and then we did this. So there's our angiogram there of the left coronary. So you can see right there at the origin, it's completely closed off, and you can see the stent had a good run of CPR on it. So we thought, well, we're stable now. Let's try and see if we can get that coronary open and just help the surgeons a little bit with better perfusion of the heart. So we went with a PT graphics wire and then went with a 4x12 Maverick balloon over that. Managed to get that balloon in, ballooned up, got the stent off, and then we had that. So we'd completely avulsed the coronary off the aortic root by ballooning it. So that fistula became a lot bigger. So, yeah. So at this stage, we realized there was no other option but to put this guy straight onto surgery and to perform the homograft replacement and to repair the coronary. So, yes, sir.
Can I ask you a question? So,
Yeah.
I don't really understand when you say you avulse it off. Like, there's a fistula, but I don't really understand the fistula.
Yeah, so when the surgeon actually went in and did the repair afterwards, what he said was where they had attached the coronary, that they hadn't completely sutured the top part of it. And so when we ballooned it, we just basically ripped the rest of the scar line around and the coronary just completely off. And he said just the way they had done it, that they had left, somehow managed to make a communication into the pulmonary. So, yeah. Yeah. So, yeah, so when we first did the conduit size and we could see that fistula through, when he actually went in and did it in the end, he could see where it had just ripped around the whole scar line and that they didn't completely. Yeah. 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 In none of the examination was there any, or in echo or anything, or in the MRI did we see anything. But our first angiogram was a pigtail, so we felt that we hadn't gone in and done anything. We didn't, we didn't feel that we'd actually gone into the coronary and caused that. So we felt that it was something that had been there. So, but yeah.
There was a coronary intuition in our lab in the early military experience, and the Ross patients have, they have such an altered RDOT because when you harvest the autograft, you drop it down onto the root.
Yeah.
And the one error in that case, if you go back and look at root cause, was the sizing of the conduit before intervention. And the fact that even if you do it with a balloon that's 24, you dilate it with a 26, or we size with a 22, and then we put in a melody with no here 24.1.
Yeah.
So if you're going to do it safely, you have to do 26 true, really size, but you're in that awkward position of conduit rupture, coronary compression. So it's
Yeah.
hazardous growth.
No.
In hindsight,
Yeah.
should have restented this.
Well, I mean, I felt that me personally, I felt the distal part looked fine, but the attending at the time felt that he really wanted to get that distal conduit where it joined in the PAs open. I think if we had have just put the valve where we were initially planning to put it, and that was further back than where the stent was, I think we would have been fine. Yeah.
I think that probably, in my opinion,
Yeah.
standing would have been.
Yeah. Completely agree. And because I don't think we appreciated how much the coronary ran directly underneath where that homograph was running, where the stent went, and so, and that was the problem. So for this guy, it was remarkable. He woke up, he pulled his ET tube out in the middle of the night and asked why his chest hurt, and was completely fine and went home with no neurological consequences from his arrest. But interestingly, his father actually had a coronary event at the time where he was having one and passed away. So his father passed away at the same time as he was under bypass. So he was a bit shocked by that. This was some research that was done by Jenny Zubler. I think she was here last year, so you guys probably know her quite well. And this was looking at coronary compression in our institution. And what we found, I think Alison was just alluding to it as well, is that patients that had a ROS had about 21% of them had risk of a coronary artery compression during a valve case. And so when she looked at it even more, any patient that had had surgery primarily where they'd had to intervene in somehow on the coronary, like a switch or anything like that, had a much higher rate of coronary compression on testing than other cases. So I say, it's not that you can't do it. I just say be really aware and be even more vigilant on those cases where there has been a ROS or a transposition where where we know that there's about 20 to 30% chance of a coronary compression. So.
I've never experienced that you won't even have a chronic connection like that post-operatively. Does that change anyone's opinion moving forward or not? Given the abnormal connection as you wouldn't have historically had on the PA side? No.
Yeah. Yeah, we felt the guy was asymptomatic, it was small, and the whole point of doing this was to try and avoid further surgery, and we felt that, that it wouldn't have been a long-term issue. So, yeah, he no longer has a fistula, so it's fine. So, so this is part of the highlight take-home points for us is if you're going to balloon test, for where you're going to put stuff, do it where you're actually going to put it. If you're going to stent further along, then balloon test where you're going to stent as well. Don't just balloon test where you think the valve's going to go. Thank you.